Diplomacy, or an approach that the National Health Council takes that I've certainly taken throughout my career, is it's not about a gotcha. We're not going to set anybody up for a recommendation or, even a conversation that for them feels like an attack.
Welcome to Chief Influencer, the show that explores how remarkable leaders earn trust, influence others, and move people to action. I'm your host, Anthony Schopp, co-founder of Social Driver. Through candid conversations and live events, we are on a quest to find incredible leaders in unexpected places, from Oscar-winning storytellers and ambassadors to U.S. senators, founders, and movement builders. We share the stories of these chief influencers to uncover lessons that you can apply to your own work and leadership. Because sometimes the breakthrough you need comes from someone facing a similar challenge in a completely different field. I'm so thrilled to introduce today's guest, a friend of mine, Randy Rutta, CEO of the National Health Council. Before we dive in, here are a few things that I think you should know about today's guest. First, Randy leads the National Health Council as it enters its second century, bringing together patient organizations and partners from across the healthcare ecosystem to forge consensus and advance affordable, high-value, patient-centered care. And we'll talk a lot about what that means, patient-centered. Number two, before joining the National Health Council, Randy led the American Autoimmune-Related Diseases Association, and he spent 36 years at Easter Seals, where he rose to become president and CEO. During his career there, he helped advance federal and state policies supporting people with disabilities, veterans, seniors, and families, and he contributed to the landmark Americans with Disabilities Act. Now that's influence, and it's something that we're going to be talking a lot about today. And finally, across his career, Randy's focused on turning policy into practice, bringing patients, advocates, policymakers, healthcare leaders, and innovators together to improve how our healthcare system serves people and helps them lead full, healthy, and productive lives. Randy, I've known you a long time. You've been a respected voice in the patient advocacy community, a public policy leader with a powerful vision for the future, and someone whose experiences advocating for people with chronic diseases and disabilities is really second to none. So today we're thrilled to call you something else, a chief influencer. Welcome.
Right.
Really excited to have you, Randy. And, as we dive in, I just want to mention, you spent pretty much your entire career advocating alongside people living with chronic diseases and disabilities. Where did the commitment begin for you? Where did it come from? And what's kept it, personal after so many years?
Sure. Well, it's great to be with you, Anthony, and thank you for those questions, that generous introduction. For me, growing up in a small town in the Midwest, you really saw how people live their values by how they help their neighbors. And within our family, my dad founded a volunteer fire department. My mom worked with the town government. There was just this sense of giving back and being involved in other people's lives so that their lives were better. And it was just that sense of community. And so that always inspired me to try to help individuals have the best lives that they could in whatever way I could be helpful, with a focus then on healthcare. I've gone from what was a pre-med focus initially, actually the practice of medicine, to really understanding how health systems and how policies could really affect, millions of people. And so it's been my pleasure to be able to push for influence, push for change at the systems level that I know and would be reinforced by, re-energized by seeing the impact then affect individuals in their lives in ways that mean something to them.
Well, when you talk about systems change, it's hard to think of a bigger example of that than the Americans with Disabilities Act. And you were at Easter Seals leading the charge when that was signed into law. So take us back to that time. What did the disability movement understand about influence that leaders and advocates today could still learn from?
Sure. Well, it was an exciting time, and seeing some of the changes that were made, now a couple decades ago, actually just become part of the American landscape, the way in which Americans lead their lives is really powerful. And I still smile sometimes when I'm on an airplane, and they're doing the presentation about where people can sit and what's expected of them, and remembering negotiating that with, the airline industry about what that means so that people with disabilities or whatever weren't feeling discriminated against in terms of being a valued passenger, and across the board. So the Americans with Disability Act tapped into a point in time where American society really valued inclusion. And so when examples of people being excluded were pointed out to policymakers, to just community leaders, to neighbors and friends, they felt, well, that's not right. And so we were able to tap that sense of, well, if that's not right, then how do we drive change? So the Americans with Disabilities Act really was a manifesto for how all aspects of society, and it wasn't 100% comprehensive. There were specific actions in housing, in transportation, and air travel that then kind of rounded out what that commitment through the Americans with Disabilities Act really was. But it was simply to say there are people with disabilities because of whether it's a physical or attitudinal or stigma type barrier were prevented from really leading their best lives and contributing to the success of their family and their community. And that resonated. And the fact that there were people across the political spectrum who had personal examples, family members, others, they spoke up and said, my brother, my sister, my mom. And that drove the movement. And then we're very fortunate, Anthony, to have leaders at the time, people like Justin Dart, Ralph Neese, Judy Heumann, and others across the nation, and from very different perspectives. I mean, the civil rights movement, the churches, others got behind people with disabilities in this way, and collectively we're able to drive change. And when the Americans with Disabilities Act was first enacted, it was kind of an unknown as to, so how will we make this happen? But the commitment was made by all parties concerned to be collaborative in how we find ways to make a grocery store accessible, or to look at a historic building and say, well, that building just wasn't built at a time when we had this awareness. What's the best we can do? So it was a good faith approach, and I think it's paying dividends, even in ways that people wouldn't even be aware now. Someone pushing a stroller loves those curb cuts just as much as someone who's trying to cross the street in a wheelchair.
Well, I want to pick up a little bit on what you said there about the personal stories of influence. So, I have a friend who is from Mexico originally,
Mhm.
and he has some physical disabilities, and he really struggles with stairs and certain things. And he said, Anthony, you do not understand how the United States is so much easier for me to navigate
Right.
than my home country and many other countries. Of course, that's because, Randy, of the Americans with Disabilities
Right.
Act stuff. So that personal story, and you mentioned the personal stories,
It
but
means everything.
there must have been personal stories of people saying, if
Ugh.
you pass this, my business is going to go out of business, or my constituent's business is going to go out of business.
Right.
Where did you learn about the personal stories and helping those stories resonate when, there's stories that are against it too. People
Sure.
that have those worries, and certainly very valid concerns because,
Yes,
like you said, there's some unknowns and they're worried about the cost.
of
So what
course.
did we learn about that then? And I'd love to kind of hear how that also maybe translates to today.
And it does. So at that time, you're right. There were stories being told by people who were just, whose lives would be transformed by having that kind of access, be able to go into the workforce, be able to go out to a movie with their friends, all of those kinds of things, which were talk about personal. But then there were the small businesses, there were the theater owners, there were people that just said, this is a big lift for us. And so what you had were people meeting in the middle. As long as there was a good faith understanding, it's like, I hear your story and I want to be supportive. Here's my reality. How do we bring those together? So there were parts of the ADA that kind of carved out or delayed implementation because it wasn't just like flipping a switch. And when you think about the built environment, that meant working with architecture schools and others to say, is there another way to have a powerful design element that's not a whole flight of stairs, going up to a building? So you had to really kind of change how people felt they were contributing to, whatever it was they brought to society, and just say, well, how can that be more inclusive? Universal design really became the way in which we looked at everything we were doing. But I
Yeah.
think, Anthony, to your point, the stories are key, and being respectful of those stories, accept them at face value, and say, so then knowing that, how do we go forward? And that's something you'll see reflected in all the work I've done in my career.
So building on that, Randy, I mean, today you lead the National Health Council, which brings together patient organizations and partners that have very different roles across healthcare. And one of the things that I think is so interesting about your organization, not only have you been around for more than 100 years, but you're so focused on a collective voice for the
Right.
patient community rather than just relying on individual organizations to advocate for their own communities, get
Right.
people together toward a common goal, which is, of course, what your work around the Americans with Disabilities Act was all
Sure.
about. Can you talk about the importance of a collective voice and the unique role that the National Health Council plays in that and how that's changed over a century?
Yeah, it really has. Although that core mission, assuring that patients are at the center of decision making regarding their health, helping them understand and then take part in their health care. Our logo, putting patients first, is not about putting us in the front of every line, but it's making sure that if it's healthcare, start with what's that impact or expectation for that individual. And as you say, when you look across the whole ecosystem of chronic conditions and disabilities, all the things that people might struggle with in their health, it is very diverse, and very areas of expertise get very specific, and interventions and treatments and supports for people get very specific to those conditions. So the National Health Council really creates this umbrella voice. We are almost 200 national organizations that are in membership right now. And what we look for is the common threads. What is it that all of us are experiencing, all of our patient constituencies? And then that's what the National Health Council will kind of establish as the banner. But what it does then is creates an opportunity for each one of those organizations to then interpret that larger goal in a way that's meaningful to their constituencies. And so it's a win-win, I think, for our member organizations and for our effectiveness. And one of the things I think that's inherent in your question is, so why consensus? You know, the way we approach the National Health Council is we convene, we build consensus, we build collaboration, and then we support impact, that influence to impact. And there's a place for everyone at that. But on the flip side, the decision makers that we're talking to, they can't react to, if we, as I say, we have 200 member organizations, and each one of those might have their 3 top priorities. If none of those are aligned, it's very difficult for a policymaker to say, well, then how am I going to advance that through my committee or through my vote? If we can show the consensus, then it's much easier for policymakers, for people in private practice to say, okay, I see a common cause here that I can get behind. The other thing is, when you demonstrate that level of consensus, you're also telling a decision maker that if you step out on a limb to help us in this space, we've got your back. So if they're only working with one organization, then there's no guarantee that all those other organizations, either because the solution doesn't help them or they weren't included and they resent that. So then there's pushback. So what we try to do is just say, we will be with you from the idea to the intervention, and then in the trenches to help your community, your constituents, understand why that was the right decision. But to do that together really makes all the difference in the world.
Yeah, and I think there are fewer examples of consensus these days. So when you can demonstrate that you've done it so long and built that credibility, I mean,
Right.
it means something. And one of the things I know, I've heard this many times from many people, is that the National Health Council is regularly sought out by policymakers and healthcare leaders
Right.
who understand that patient perspective. And they say, look, I mean, they can't go meet with 200 organizations individually, although I'm sure
That's
they
right.
time to get that. But if we speak with the National Health Council, we can understand what shared perspective those 200 organizations have, because it's consensus driven. If there's a
Exactly.
major outlier, you're not going to be able to do that. So I'd love to hear a little bit more about the power of that. And then
Sure.
also, I know that, being heard, it's not the same as changing the outcome. And
Right.
so I'd love to hear maybe where you've seen the National Health Councils being sought after, how that has built institutional credibility that maybe triggered some sort of action where you've seen that
Sure.
in action. Because I know there's a lot of examples of it.
There are a lot of examples, but yet that is how you would measure success, right? You know, that we were invited to be a part of a conversation, our viewpoint was respected, and then you see. So as the decisions start to emerge, is there language that we inserted? Is there a recommendation that got reflected there? And we see that all the time in legislation, regulation, just policy making, and in private practice, where different parts of the healthcare ecosystem respond to a message. And we really don't, I get excited if it's something that we've really sponsored that we can then see direct evidence of. But this is not a time, and that was true at Easter Seals all throughout my career. It's not a matter of claiming credit then for that, because nothing is happening without, a collaborative effort. As the new administration, the current administration was coming in, so early last year, through the summer, There were lots of efforts to try to engage with the administration, understand what they were thinking. So one example is I did have the opportunity to visit with the Domestic Policy Council, a wonderful conversation on some topics that were important to them. I had our members of our National Health Council board joined me in that meeting. And if the individual we were meeting with said once, they said at least a half a dozen times, well, 200 patient organizations, that's a big deal. So they were impressed by the fact that we could indeed represent that many voices. They're thinking that means your input is going to have value because it's coming from all these perspectives. They literally asked us to put together a resource list of the research and findings and data that were coming from our members. It was 38 items I think we were able to put forward. It was around pediatric issues. And then they knew that if something went forward, they could call on us to say, well, there's a stakeholder that was representing a large group of people, large group of interests that was part of this decision. Why don't we let them share why that was the right thing to do? So there's an example of how in the administration, the people that we were meeting with, this is true in Congress, certainly across federal agencies, they do their homework. They look to see, well, what is their record? Who are they including? What kinds of positions are they taking? And that is that stature, as you suggested, that one, gets us invited to the table, and then two, gives us influence then on those decisions that are being made. And we'll probably talk about this later, but we're always very honest. This is our mission. This is our membership. Here's how this issue intersects with what it is we would be recommending. We'll point out when one path may have resistance from other parts of the community. We'd want them not to be blindsided. And we want them to know that we're giving them our best thinking on what it is we're asking them to do.
So this approach to influence, I mean, I think we can tell why it is so powerful. You're hearing that, wow, 200 organizations. I want to switch gears a little bit to talk about the role you play as leader, because, you are in a way the mayor, the referee, the, leader of this community.
Yeah.
And you have to exert your own personal influence to navigate this. It doesn't just happen naturally through the organization, although you have systems, I'm sure, to facilitate, but it requires that personal leadership. And as we've talked about, I mean, for decades, that's something that you have honed and exerted. What have you learned when you're trying to build consensus among different groups who have different experiences and different points of view, and they maybe share a broad goal, but they have really strong, opinions about how to get there? How do you, Randy, as a leader, build that influence on the inside and find that common ground? What are some of the tactics that you have learned? How do you approach that?
Well, I think the most important thing is to listen, because you're generally those kinds of conversations about problem solving or migrating a pilot project or something that's working in one area to other parts of the system. So the best thing to do is listen to those people who are most expert about it or most affected by whatever the issue might be. So listening, being respectful. If someone is sharing their opinion, particularly if it's patient experience, authenticity is the number one, currency that really comes with that patient story and that patient experience. So looking for that genuine, input from a real experience or real knowledge that person brings forward, being respectful of that, and then talk about that issue. How do we go forward in a way that recognizes the framework that we're trying to operate in? And I think for our work with patients themselves and patient organizations, you think about, well, how do these stories surface, or how do you activate? We feel that our member organizations touch the lives of 200 million Americans all the time. If you're a person with diabetes, the American Diabetes Association is at the kitchen table with you at dinner time. I mean, they are a trusted resource. And so what we look to do is, how do we leverage that in a way that helps someone understand that we've got their back? And then that's our job to say, well, if that's your experience, there's an opportunity coming up to meet with your legislator. It's a town hall. Go and talk to them about it. Send a note. Be part of an advocacy day. So the expertise that we can bring doesn't change their message at all, certainly not their experience or even what they want. What we can do is say, what's the timing? Who's empowered to make that decision? Are they in a part of a process that is ready to hear that input? What are the different avenues? So we just simply provide the insight into when and how that important contribution can be made. And that's a really nice synergy, I think, from the patients and the advocacy community to kind of the people that are more a part of the government relations or public policy process that just understand where it is there's a real opportunity or how you might need to approach something slightly differently. Mhm.
And do you find yourself in a position where you're getting calls from members who might have different points of views and you're helping to try to find a way to bring that together or decide, "Oh, maybe this isn't the right time for us to advocate for X and we're going to focus on Y." I mean, I think every leader nowadays is having to grapple with those things. And
Sure.
I feel like you probably could teach a master class in how to navigate influence on the inside.
Right. Well, because that influence is 365 days a year sort of thing. I mean, it can't be transactional. You're at risk if you put everything into one specific ask or one specific area of activity because it may or may not go your way for the champion that you have or for your constituents. And you never want to close doors. I mean, what we know about policymaking, it is a process. It kind of never really ends because even when you have a major victory, you're already looking over the horizon to say, well, what will we learn that causes us to build on this or reform it a little bit? And so you want to know that these policymakers, and when they're in office, that's probably when they're most empowered to be influential in the process. But oftentimes these people then go on to other kinds of leadership roles and things, and you built a relationship that you're their go-to organization. So Anthony, that really is kind of how we approach, not just building the consensus and leveraging the presence, but understanding that and we really use, and I've always done this in my career, it's in good faith. If we're having a conversation because you're part of a policy making or healthcare ecosystem, then I am going to give you the benefit of the doubt that you are participating in this process to make a difference in people's lives. In this case, we're focusing on health. And so how do we find the common ground and help each other achieve mutual goals? And then on occasion, congressional offices will say, we have this idea, we want you to endorse it. And it's like, well, we need a little more detail. So we'll ask for that, and then we'll work with them on it. On occasion, you will have a decision maker or whomever propose something that really is not in the best interest. So there's like two times when you might actually say, I don't know that we're going to be able to find common ground here. One might be if it really is antithetical to, what it is what your core values are all about, what your constituency needs. We can tweak, we can, make modifications, but we're never going to deviate from that. And then on occasion, we may be asked to weigh in on something that really is in healthcare or in our area of expertise. And that happens a lot these days as we look at systems change. And so when legislators call and say, well, what do you think about, this proposed action? It might be a business structure thing. It could be international trade issues or security. I always, if I'm going to react at all, has to be, well, for patients, this is what that topic looks like. And I think that's proven to be very successful because we've been able to contribute to a lot of conversations that may seem tangential, but the decision makers want our view on that, and they want it to roll up into something that we can all be supportive of.
As I've looked into just more about the work that you all do and the
Mhm.
victory that you've had, when I think about an example that goes beyond just listening, but really formally incorporating the patient experience into the process, I think patient-focused drug development is an example that stands out. What did it take to turn patient insight into something that decision makers were willing or required at this point to consider in kind of the system? I'd love to hear more about that.
Well, there's a point of intersection between kind of our philosophical goal, our reason for being, and an intersection with a process then that's defined and important to patients in terms of medicine or device discovery, and then how the patient perspective gets folded in. So it was many years in the making. Patient-focused drug development, part of 21st century cures, where we're really looking at a framework for how it is. In this case, it's primarily the FDA, but then some of the supportive research and evaluation components, both in government and outside of government, saying, well, first thing we need to do is have some consensus on how do we measure real world evidence? How do we validate patient experience data to come into a formal decision-making process? And so there was kind of there's always been a public participation process where I've done it myself, where you go in and you speak to a committee making a tough decision, and you provide the kind of context around what it might mean to approve a certain drug or whatever it might be. But then what you're getting at is how did the system, which is a science data-driven system that has very clear milestones and markers, start to then literally legitimize and expect that real-world evidence, that patient involvement, those things are built into the system. And for that, we needed to just do the work on our side. Create pilots, create validated systems, evidence-based systems that then could stand up to scrutiny so that it wasn't just hearsay, but it was collected in a certain way, brought forward in a certain way, that then it could be used in a formal decision-making process. So, and I would have to say at the time when that was happening, you just had a readiness for leaders in that process, primarily at the FDA, that were open to it and good partners to us. We ended up creating around that same period of time the PCORI, which is the patient outcome centered initiative, where they're really looking at how is it that things are measured with a patient lens that then are relevant to the research and decision-making system. So it really was a lot of hard work that managed us to take a goal in a sense that it's right to have patients included, and then respond to what the system needed and how that information could come forward.
How do you know, Randy, when your influence is about being diplomatic versus when you have to disruption? Because sometimes you're trying to disrupt a system if it's not working for patients. How do
Right.
you balance that and figure that out?
Well, a little disruption, a lot of disruption, I think is exactly what patients are looking for. Of course, they understand it from their own experience, and it's our job to kind of translate that into what was a unique experience that maybe that particular set of actors needs to address, and then what is it that could be supported by systems change. Diplomacy, or an approach that the National Health Council takes, that I've certainly taken throughout my career, is it's not about a gotcha. We're not going to set anybody up for a recommendation or even a conversation that for them feels like an attack. So the language we use is going to be absolutely advocacy driven. It's going to be mission driven, but the language we use is going to be, help us understand or invite us into a conversation from your perspective as to why this is our perception, and just build from there. So it is that good faith. And then there are occasions when it might be a business practice, it might be a policy that's evolved over time, where we simply have to say that absolutely has to change. And we're always going to start with a consultative, consensus-driven approach. But at the end of the day, if it takes saying, look, we need to go to the decision makers exclusively to try to push for a change, then it's just kind of our word against whatever the opposing view may be. And then it's up to the legislator or the policymaker to try to sort that out. But diplomacy, always. What the other piece that I'll say, though, that's the National Health Council. Our culture is to be embracing and inclusive and collaborative. But and this is true in the disability community as well, but if you look at what get things done, advocacy occurs across a full spectrum. So, for example, when we were promoting access to public transportation, and the system did not know how it could possibly help people with wheelchairs ride on buses and all of that sort of thing. There were people in wheelchairs chaining themselves to buses, groups that were doing that. And then you had my organization, Easter Seals, and others just as passionate, but saying, well, we can sit down at the table with you, representing the full spectrum of concern, but talk about it in a way that understands where you're coming from or what the constraints of the environment might be. So that's where that spectrum of advocacy rolls up to real net change.
This episode is brought to you by the George Washington University Graduate School of Political Management. Through flexible graduate degrees and certificate programs, GSPM prepares today's professionals to lead in strategic communications, public affairs, advocacy, and politics. Learn more at gspm.gwu.edu. And I don't want to put words in your mouth, but when I hear this, I think maybe your philosophy of influence, we could even call it diplomatic disruption.
Yeah.
You have to disrupt the system, but there is a diplomatic way to approach it when you have to build consensus and build trust. That's been lasting, that you've been building trust for over a century.
And we are in that position right now. I think the American healthcare system, as amazing as it is, is not, fully accessible to every person that would benefit from, the expertise that we have. And we have, have a 20 mid 20th century system that's been modified and patched together and evolved over time. I've been a part of that process all along. That now, in the face of 21st century medicine, diagnostics, interventions, prevention, is starting to fail us. And what's interesting is that I don't think there's any part of the healthcare ecosystem that I've experienced that people don't acknowledge that.
Or,
So we're positioning patients as the way forward by saying everybody has so many vested interests or ways in which they've structured to make the current system work. If we're going to challenge or be disruptive, as you say, to that process for a better outcome, you start the conversation by saying, well, what are the pain points you are experiencing, and how might going forward together in a disruptive way lead
yeah.
to a better result?
What do you think is the deeply held assumption or the incentive that we have to be willing to reconsider to truly redesign the healthcare system around people in today's era?
I think the number one kind of concept that I see that comes to the table and we have to confront is that we can only look at solutions that save us money from where we currently are. That anything that's going to add costs, it's really the value proposition right now is almost exclusively defined by economics. How much is it costing us? How, if you're asking us to do something, whether it's the public sector, Medicare, Medicaid, or whether it's commercial insurance where employers are providing health insurance for 49% of all Americans, how do we say the realities of the experience you're having is we're paying so much more and experiencing either inconsistency or less in terms of the outcomes or benefits? How do we address that? And I think the number one thing we need to do is change the value equation. So we're not only looking at what's possible, what the current experience is, what's possible through the lens of, well, how much money are we spending and how can we reduce that? But better to say, well, how can we invest current resources differently by prioritizing maybe prevention of disease? If it's a disease model, could we get ahead of that? Or invest in having patients understand that we're moving towards something that's curative or manageable. People are leading their lives now who never expected to live to a certain point. People with cystic fibrosis are living into their 30s and 40s and beyond. That was not even possible not that many years ago. So how do we account for that in the actuarial view? And right now, our system is overly focused on the financial methodologies that we have for the current system, which is very inefficient, I think, and not always pointing toward a patient outcome or a benefit. And then it's also time limited. Most of the decisions that are being made, whether it's CBO estimates or whether it's a health plan establishing its insurance design, are all done in 12-month cycles. And so people lead their lives over the course of their lifespan. And so how do we have the system acknowledge that there may need to be investments in an individual at certain points in time for their health that will roll up to a social and ultimately a systems benefit? But it's gonna have to call on the individual players not to define success by what can they accomplish in a 12-month period, and then avoid any kind of investments in someone's health if they don't feel like, one, they're going to still be insuring that person or employing that person, or two, whether that savings won't be generated enough. So it's a mentality that needs to look at investment and investment to outcomes over a period of time that's more reflective of how a person leads their life.
Yeah, there's not a lot of things we value. I mean, you think of a business, they're certainly looking
Right,
out more than 12 years, a strategic plan.
right.
For college, we're looking at our 4-year college experience and what our major is going to be, limiting to 12 months makes it really hard to see the big picture and to make the right long-term investments. I think
It
that's
it does, and each part of the healthcare ecosystem has those kinds of metrics. For an insurance plan, they may say, it's as long as 26 months is the only expectation they have to have someone within their plan before they change jobs or the employer changes the insurer. So you understand, but if the entire system made the kinds of investments that then everybody benefits from, as those individuals move from one plan to another, one employer to another, that investment will have occurred. They'll all reap the benefit. But we almost have to kind of join hands and embrace that leap together to make that really work.
Yeah. And, you know, you've talked a lot about human flourishing being like the bigger goal behind healthcare that we should be
Right.
focused. And if we're just focused on, cutting at these little levels, I mean, we sort of lose, we're not seeing the forest for the trees, right? I mean, it's like,
Right.
what's the goal? We want people to flourish. How do you shift folks' focus to even think about that? Because you don't hear that in a lot of conversations about healthcare these days.
Right. Well, we're hearing it, we're hearing it more and more in the AI or technology space, which is such a emerging area of impact across healthcare and across society, where that concept that I don't know if it originated at Harvard, but certainly has been a focus of a lot of the contributions Harvard had made to just collective thinking is, and if you apply it to healthcare, it's even more specific. If you just look at a disease, and then you look at a person as their diagnosis, and what we know is most people, particularly as you get older, have multiple diagnoses that define who you are. But that doesn't actually define who you are. That just says, here are the factors I'm dealing with in my health, managing my health. Human flourishing recognizes that a person is more than just, the sum of their diagnoses. They are a person who has a family, is a role in the community, that derives satisfaction and pleasure and joy from a whole range of things that health and being healthy and healthcare should support. But that the end goal shouldn't just be getting you through this episode of care, but it's how does that then allow you to attend your son's wedding, or, be part of the things that are important to you. And
Yeah.
because health only succeeds if each individual is making decisions every day about their own health, in favor of their own health, then that all of that rolls up into population health, and we're better off for it. But you can't think that someone thinks of themselves in their lives in such segmented fashion. So human flourishing simply calls on decision makers that are thinking about these kinds of change or these kinds of investments to just elevate a little bit to, but how does that affect the whole person? And for the disability community, for chronic conditions, for the National Health Council, we've always been about the whole person. We did some research about what is the patient experience currently, and by interviewing patients, and said, tell us how you are being helped and hampered by the healthcare system you're experiencing. And it was interesting enough, you thought there would have been a lot about access to my doctor, access to my medicines. Most of it is around the less tangible things about, I don't have the transportation to get to and from participation in a clinical trial, or I'm really struggling with how I, literally navigate the nuts and bolts of interacting with healthcare rather than the healthcare itself. So if we think about that total experience and solutions that are really going to help us help people and help the system thrive differently, human flourishing is an absolutely excellent lens to use. And then you build back from that. So how is a person being supported in their physical, mental, emotional, social, and spiritual health? We're talking about algorithms used in AI that actually are reflective of the population you're looking to support from all of those indicators, including spiritual. I think the Vatican is speaking out more and more about how they feel AI and emerging technologies, including in healthcare, should really help the whole person achieve a life that's enviable and meaningful to them. Yeah.
When you gave that example about like the assumptions of what we're changing in the system, and that, transportation might be that, it reminds me, I think any leader, whether you're working on a systems change or even inside your organization, sometimes it's so important to gather the data, but also hear the stories about what really matters. A business leader told me many years ago, what do you think keeps somebody employed at a job? Well, the data is overwhelming. If they have one friend at work, and if their technology works for them, like, desk chair is not uncomfortable,
Right.
or it's not super slow. Those, if they don't have either of those things, there's a very high risk that they're going to want to go somewhere else. So there's so many other things that we all think about, but sometimes it's easy to forget, like, oh, maybe somebody needs a different mouse for their computer, or, they need to just get to know somebody at work. And I think that is such a great lesson. And it ties right what you said about, human flourishing and what we need, patients need, all of us need from the healthcare system. And it might be, about just getting to the doctor. And that might be here. And so I'm hearing from you, influence is really about understanding the perspective of a person, understanding that, of course, putting patients first, putting patients at the center, everything that you've been doing for your career. And it's just a great thing for any of us listening to think about and go, how are we doing that, on the inside, on the outside? And what are some assumptions that we're making that, maybe should be challenged? Because if we got a little bit more information, qualitative and quantitative, from the people we're serving, it might inform something
Yeah,
that we're doing.
absolutely.
Now, Randy, you also talked about technology and AI. And I think it's really important we take some time to hear the really cool work that the National Health Council is
Sure.
doing around your patient experience and innovation center, because I think that it's natural that the NHC is the organization saying, wait a minute, with AI and digital health tools, we need to make sure patients and caregivers are part of this process. We need to make sure that their perspective and their voice is included. And by the way, if it's part of the innovation, it's
Right.
actually going to get us to a
Yes.
better result. So it's not just a nice to do thing. It's actually probably in your self interest if you're developing these platforms. Can you say a little bit more about that? Because I think it's
Sure.
so exciting that you all are taking this legacy and the century of experience and the trust and credibility you've built, and that you're making sure that that is part of these innovations that, we're all reading about and hearing and experiencing every single day.
Absolutely. Well, it was several years ago as it became more and more clear that AI, moving from predictive to generative AI, was really creating opportunities for change across society and in healthcare. And it was our board that said, we had been having some webinars and some sessions and things like that. It wasn't that we weren't active in that space, but there was a sense of urgency that if we don't help empower patients in their own lives through the benefit of these emerging technologies, and then also our patient organizations, if they're not conversant on, so what technologies can we trust? What should we bring into our organizations to be the best nonprofit, organization we can be? Then we're going to be left at the margins, and that all the benefit that we would stand to gain at a patient level or at a patient organization level, and all of the rich experience we would have to contribute to the design and development and marketing of technology tools that really do make a difference in health would be lost. And so the National Health Council launched kind of a two-pronged approach. Internally, we have an affinity group on AI, and we do peer-to-peer learning and networking and what systems are working for you. That's a monthly convening and then a place where our member organizations and others can kind of have as a resource. But we understood, and that was after countless hours that I've spent at Stanford and engaging with the Coalition for Health AI and the Digital Medicine Society and the Consumer Technology Association, others, literally interacting with people who are in their garages and coming up with really cutting edge technologies. It's not a skill set that they necessarily have on actually reaching out to the end user in advance. There was a little bit of a mentality that, well, we're just going to build it and it's up to you to figure out how to use it. And we said, well, that could be good in a lot of things, but in healthcare, seems like we should hold ourselves to a higher standard. So the Patient Experience and Innovation Center was created as a place for the tech sector and other parts of that innovation arena to be able to find patients. Because when you did talk to them, individuals, leaders of these tech companies, big and small, startups, they would just say, oh, I get it. Of course, it would be better if we had a focus group up front to decide, what we might do or whatever. But we can't find patients, or we don't know what they want. Or if they do engage them, this is on us. Do they have the knowledge sufficient to sit at the table and really contribute? And so we created PXI, the Patient Experience Innovation Center, to say, well, we need a learning lab for us on the patient side, patient organization side, and for the tech sector to just simply understand how the process works and how we might be engaged. Another whole section is about a matching. It's like a dating service where if there's someone in the tech sector that says, we're thinking about this, we'd love to pull 30, 50, I guess as trusted testers is one of the terms they use. Could we be an avenue through our members to identify those patients? Absolutely. That's part of our mission. So we're really working in that way. When some of those conversations really elevate to saying, let's do a pilot, let's actually do this forward, we have a sandbox for that in terms of projects that we could all learn from and help advance. And then it's just simply collectively for all of these, we've got more than 2,000 people, I think, that are actually engaged, over 200 organizations, including some of the leading, tech sector players that are out there, are starting to experience this. So we make sure that there's a network there where they can know each other and then share their perspectives. So we understand, well, what's driving you? because so much of what's happening in healthcare with regard to application of technology, certainly in diagnostics, certainly in clinical decision making, ambient listening when you're with your doctor in a consultation, but a lot of it's business to business. It's just really accelerating or not necessarily leading to a patient benefit, but it's hopefully adding value within the system. And if you're talking to someone who's in a startup mode, they're just like, dude, I am hoping for an IPO. I want to just get to the point where someone buys what it is I'm doing. Okay, I get that. But how could we design it in a way that it really makes a contribution beyond just accelerating a decision that may or may not break in the patient's favor?
Yeah. Well, and if you do it right, it's probably going to be a more successful
Exactly.
right. I mean, and that's so there's some self-interest there too, which is, not necessarily a bad thing in this perspective. I think it is just so cool that you're doing this because you're right. You identified the problem. Hey, we love to get that patient voice, but we don't know how to find them. We don't know how to do that.
Right.
Well, here's an expert with a century of experience that we can actually help you do that. And getting
Right.
that patient voice is going to be better for everybody, but it's actually probably going to make whatever you're building better
That's
because
right.
if we serve patients well, then patients are probably going to,
That's right.
start yelling about it, whether it's they don't want to use the product or whether they don't like it from a policy.
And that has happened, millions and millions of dollars being invested in a particular device or something like that. And then for some odd reason or for a certain part of the population, it's just not going to work.
Yeah.
If you have eczema and you have to do a wearable, that's challenging. So how do you manage that in a way that everybody wins and benefits? Yeah, one constituency that I've been talking to more and more, and I see that across our member organizations, is talking to investors. Because so much of our healthcare system is a business, and it's absolutely motivated by shareholder return and benefit. And so having us talk to investors about if you're making decisions about where to place your resources, and some of these companies are really showing that they're reaching out to the end user in advance of making these decisions, we would encourage investors then to value that and maybe rank that company or that applicant higher than someone else. And then we're trying to instill that in some of the values and principles and systems that a lot of these major players are endorsing. And there's not been resistance, Anthony. It's been a more of, oh, okay, how do I get there? But then we have to just be ready to respond when they're ready for some kind of support. And that's the resource we've created.
Yeah, that's awesome.
Yeah.
Well, thank you for sharing more about that. I know that it's moving fast and there's a lot happening, but I hope folks who are listening in and are in the technology space check out what you all are doing. And
please do.
Randy, just one final question I want to ask you after this, just such a great discussion. Always fun to talk to people who I know and then to learn more and dive in with them because of course, I always learn new things, even though we've known each other for many years. But you've had just an incredible careers we've talked about today. As you think about this idea of influence, how do you define influence today? And has that definition changed over the course of your career?
Yes and no. It's because it's the fundamentals. What is it when I think about who do I look to as influencers, or how might I have interacted in a way that then demonstrated, oh, there was real influence leading to impact there. The core elements of what comprise that are pretty basic. How they might get flexed or emphasized, or the language I might use, that definitely changes and has to be very much in the moment. But it's about expertise, that you're contributing some knowledge and a perspective forward that actually makes a difference. 100% honest, that you're genuine, honest. You share what you know and you share what you don't know, and commit to working together. That you do have a vision. I mean, right now for the National Health Council, in some ways, the current landscape, which has got a tremendous amount of change that's in the works, and also an understanding that we need to kind of look to the horizon. We talk about how is it that we're performing in the here and now, and then how is it that we're contributing to the transforming of what we know is the system that we want to live with. And so it really is being honest, being genuine, presenting the facts, saying what you know and you don't know, being a consistent resource. So it's not a one and done, in and out, but it's a relationship that you've established, and then have some goals. Just the engagement for the sake of engagement is really not the best use of everyone's time and energy when it's so clear that we want to drive toward change. So I think it's being authentic, it's being honest, it's being, having the facts, it's having the stories that back up so people not just see the charts and the numbers, but can actually see the faces and people they may even know, that helps make it compelling. So I guess the last ingredient would be passion, that energy, that passion to be inclusive and drive towards something meaningful.
Well, you obviously have that passion and you've
I do.
demonstrated it in your career. And you know what I love about what you shared there at the end is, and that, came out through the entire interview, expertise is very important to influence. And we know that, having credentials and so forth is part of that. But you talked about the faces, the authenticity, the passion, the lived experience. And I think
Yes.
in today's world, that lived experience has perhaps even more weight
Yes.
because folks want to hear from somebody and they may actually trust the lived experience of someone versus the acronyms behind someone else's name. And
Right.
so when you can bring those together, which you do so well, right? The patient voice, but you're bringing the
Love it.
lead who have the best
Hmm.
expertise. That's really the key. And it's a complex time. It's a challenging time right now, obviously. But I think that we can think of you perhaps, Randy, and I wouldn't have necessarily come into this conversation with the phrase, but now I'm going to keep using it as a diplomatic disruptor. And for decades, you've done that. I mean, you were at the forefront of the Americans with Disabilities Act, of getting that passed. And you shared just that was very complex, but finding ways to bring people together to
Right.
achieve that common ground. And, it wasn't easy. It was going to be some big change, but there's a diplomatic way to do that.
Right.
And that's what you have been doing with the National Health Council. And there are a lot of wins that you've had. Sometimes they're big wins that everybody sees. Sometimes there's little things behind the scenes that
Right.
matter a lot in the system. But if you're not an expert in the system, you don't realize that that rule that was written in that,
Right.
department is going to make a big difference. But the NHC is just so trusted. Policymakers seek you out because they say, hey, this is the organization that gets the patient voice and we can
That's
trust
right.
that they're going to get a consensus of these 200 groups. And if they have that consensus, that's going to mean a lot. So that's
Yeah.
kind of your approach to
It
the
is.
diplomatic disruption, if I can
It
say.
is. Well, I appreciate that label, and it's all grounded in kind of reflecting back into our own membership, the decisions that we make, the communications that we put out, the positions that we take. Those are not just me saying, "Yeah, let's do that." There's a process for inclusion, consultation, fine tuning. That's why we can bring 200 diverse member organizations, some in very different roles. I mean, our patient organizations, even there, someone with a rare disease, someone with a more established or neurodegenerative type disease, there's very different perspectives on what good healthcare means. And then we have insurers and biopharma and device management. All these folks are part of this system. But giving them all an opportunity to get behind our mission-driven input to then feel like they've at least contributed, that they can support, is what really adds up. I mean, if you're very gracious in saying I have influence, but it's really the influence that comes from the collective
Mhm.
respect and care that we put into any of our input into the system for change. And it starts with the patients, their caregivers, every single day. The one thing I'll say about the current environment, it has not been the easiest environment to influence because, Congress has been moving forward in different ways in terms of advancing legislation, all of that. Our patient organizations have been more present on Capitol Hill, at state houses than ever before. So even when the systems themselves are in a state of disruption and trying to sort out, we have been showing up. And by we, I mean our patient advocates themselves
Yeah.
and the patient organizations facilitating that more than I have ever seen in the course of my career, which means even in a difficult environment where decision makers are challenged to find the vehicles to move something forward, they are buying in, they're working with us to create solutions. So when the time is right, we can act. And that feels really good.
Yeah, that's awesome. Well, Randy, thank you so much for being with us, for sharing your story. And for folks who are interested in learning more, check out the
Sure.
National Health Council. Check out Randy Rutta on LinkedIn, and there will be more exciting news coming.
Thank you so much, Anthony. I really appreciate this time together.
Thank you for tuning in. Chief Influencer is a production of Social Driver in partnership with the George Washington University's Graduate School of Political Management and the Public Relations Society of America National Capital Chapter. Social Driver is a communications and digital agency that helps organizations and their leaders build trust and break through. with people-centered communication strategies, digital campaigns, and future-ready websites. From brand strategy and thought leadership to creative content and digital experiences, we combine senior counsel with hands-on execution to turn expertise into influence. To learn more, visit socialdriver.com. For show notes, past episodes, or to nominate a future guest, visit chiefinfluencer.org or follow Chief Influencer on LinkedIn.